important based on studies looking at antibodies. Most of the antibodies that have been described in Crohn's and ulcerative colitis, and specifically in Crohn's, are not antibodies against the intestinal epithelium. They're actually antibodies against different components of the intestinal microbiome, which also suggests that that is a fundamental feature of these diseases. And we recognize that a lot of these changes are not occurring in isolation, but are occurring in parallel with changes in environment, and that these changes in environment are actually fundamentally important in understanding why these diseases have increased in incidence over the past 20 or 30 years. There are a number of different factors there. I've just listed some. Each of them in themselves can take the 20-minute duration of the talk, but we recognize that there are a lot of different changes that have happened in different environments over the past 20 years that contribute to this. What I wanted to focus on over the next 10 minutes or so is how we have changed our thinking in management of Crohn's disease and ulcerative colitis. And I think in the panel, we can actually discuss how much of this changing thought process can actually be implemented in every different region. But if you even look at when, I did my GI fellowship, which was about 15 years ago, the concept was still that, you want to do the sequential treatment of Crohn's disease or ulcerative colitis, where you move through each drug category, but you save your most effective drugs for when you feel you might really need it. So there was this concept of trying to treasure what you have, right? That was the old paradigm. But we've moved on from that because we've understood that waiting for when you needed to institute these effective drugs is actually costing you a lot of advantage, where you could have reversible inflammation that you're not intervening on. And so by the time you actually use these drugs, the disease has advanced to such a degree that the drugs are not able to have any effect. Right? And one of the first studies that started establishing this, and this has now been demonstrated across different treatments, is that early treatment is critically important in giving you the biggest bang for your buck. So this was a post hoc analysis of the PRECISE trial, which was a trial of certolizumab versus placebo in moderate to severe Crohn's disease. And what is important here is that they looked at the response rates across the different durations of Crohn's disease and ulcerative colitis. So if you see the very first bar, that was the entire trial population, and you see a delta of between 62 and 36 for active treatment and placebo, so a gain of about absolute 30% increase in remission rates. But if you look at those with just disease less than 1 year, which is very newly diagnosed Crohn's disease or ulcerative colitis, you see that the bars separate that much higher, so that you actually get a delta of about 50. So you're getting much more value for your treatment if you start treating people early on. And so that was fundamentally a change in how we stopped thinking about saving drugs for when we needed it. And this was also demonstrated very well in this trial that everybody involved in IBD care should know. This was published in The Lancet in 2008, which was a multi-center study across Europe and North America, where they took people with Crohn's disease and gave them either infliximab early on for a few doses and then sort of monitored them on azathioprine, or they did their traditional sequential strategy where they did your 5 ASAs and then steroids and then azathioprines, and if that didn't work, you really did infliximab after that. What was striking in this trial was that if you look at the group, which looks at your endoscopic appearance, even though at the end of the study, both groups were using azathioprine at the same frequency, and very similar proportions were on infliximab as well. So eventually they got there. They only differed in when infliximab was introduced in the treatment paradigm. And you see a tremendous difference again. The green group, which is disappearance of ulcers because of early top-down strategy, they had very high success rates with treatment, whereas the group that was in yellow, which even though eventually they ended up on the same drug, they didn't get it early enough, and so they didn't have the same degree of endoscopic response. So again, this was a trial that very nicely demonstrated the value of treating early rather than saving till you're really sort of needing it. And this was the REACT trial, which is another recent randomized trial. This was led out of the group in Canada, again, very similarly showing that your early combined intervention is important in preventing disease-related morbidity. So that was sort of the first concept, where we're not thinking anymore of saving the drugs till we actually need it, but focusing on early use of biologics, whether it's biologics or effective treatment, for actually having the greatest efficacy. The second sort of change in thought process, and this is also a pendulum that has swung back and forth over the past little bit, is avoiding combination therapy to minimize the risk of side effects. And so this was the thought maybe 10, 15 years ago. You don't want to use these drugs together. But we know that that's not the case anymore. And we're all familiar with the SONIC trial data. So this was a very important trial in the management of IBD, where they looked at a combination of azathioprine or infliximab alone, along with using these drugs together, and showed that the combination works really well and works much better than either drug alone. And this has been shown with some of the other biologics and some of the other immunomodulators as well. It's also been shown now with recent trials that have looked at combination biologics. So it's not just combining with immunomodulators, but actually using two biologics. This was data presented at the DDW meeting this past year, looking at using either an anti-TNF or an anti-IL-23 antibody called guselkumab, or using them together, showing that if you use them together, not only was it safe, but you also had much higher rates of remission, whether it's clinical remission or endoscopic remission as well. So that's sort of the second change in paradigm, where we're not as worried about using these drugs together. Maybe 20 years ago, these drugs were new, and there was a lot of concern about infections with these drugs. We know that that's not the case anymore, and that you can increasingly use these drugs together to get the sort of biggest value for your money in arrest disease. So that's the second change in paradigm. The third change in paradigm is not so much about the drugs that we use to treat it or how we use these drugs, but what our target is. Right? Traditionally, in Crohn's disease or ulcerative colitis, our treatment goal was that the patient is asymptomatic. So if they're not having abdominal pain, if they're not having diarrhea, then you would consider that a success, and you just keep them on that drug till when they develop symptoms. So this was sort of the traditional way, whether you do using the CDAI or the SCCAI or any of the other symptom-based disease activity scores. But we know that even though this strategy is easier to do, that these symptoms correlate very poorly with evolving disease damage from underlying subclinical inflammation. And then so this was a Norwegian study that was published showing the value of mucosal healing. This was a population-based cohort looking at patients who were diagnosed with Crohn's or ulcerative colitis and then had a colonoscopy about a year or so after they were diagnosed, and showed that if you had achieved endoscopic healing by that point, your outcomes at 5 years were much better than if you had not achieved endoscopic healing. So showing that there's incremental value to having healing of your mucosa rather than just resolution of symptoms. So this is the third change in thought process in the management of IBD. We're also not only focusing on endoscopic healing, which is at this point that's sort of given as a therapeutic target for us. That's sort of the very minimum that somebody needs to reach. But we're now looking into, is a deeper level of healing achievable? Is a deeper level of healing valuable? And what sort of the role of deeper levels of healing is in clinical practice? And so this was looking at histology, showing that even in those who have healed the mucosa, those who have persistent histologic inflammation do worse, suggesting that maybe your histologic resolution should and could be a target. That was sort of this treat to target strategy was exemplified by this CALM trial, which was a trial that looked at either a symptom-based treatment strategy or a fecal calprotectin-based treatment strategy. So essentially, these were patients with Crohn's who followed the same treatment paradigm with starting adalimumab. If that didn't work, having the dose increased to once a week. If that didn't work, having azathioprine added on. So that treatment paradigm was the same. In the first group, that treatment change was made if somebody had symptoms. In the second group, they got fecal calprotectin measured every 3 months, and if their fecal calprotectin was high on consecutive measures, they had that treatment change made. The treatment changes were the same. And what this CALM study showed was in the group that had this biomarker-based assessment of remission, rather than just resolution of symptoms, the outcomes were much better in terms of either clinical or endoscopic remission. Right? And so we've come up with sort of different consensus groups laying out the different levels of healing that are necessary. Symptom resolution is a given, you need that. Endoscopic healing is increasingly a given that you need that. But whether you need radiologic remission, whether your MR or CT scans have to be normal, whether you get an intestinal ultrasound that shows You don't have transmural inflammation in Crohn's, whether in ulcerative colitis, you need histologic resolution. All of these are still points of debate, but we know that that's where the field is heading in terms of your evolving therapeutic algorithm, right? So that's the third change in paradigm, symptom resolution.